Yeah, thank you so much, Ramesh, for your kind introduction, and thank you, the Boringa Ringalam people, for giving me this opportunity to be the speaker of this evening. So, without much delay, we'll just start. This is Trajectory Talks, and simplifying today's subject and topic is simplifying the trajectory of type 2 diabetes mellitus, a broad patient centric perspective. And I am Dr. Sepuri Krishna Mohan. I am an endocrinologist at my own Sepuri Diabetes and Endocrine Center, Kurnool. So, these are the key priorities across the lifetime trajectory of the people suffering from type 2 diabetes mellitus. So, you can clearly see the slide like the younger age and the middle age and the older age. The priorities and the modality of the treatments, they drastically vary with the age. So, like younger age, the preventing the clustering of risk factors is very important, and the opportunistic screening for timely detection is also important. So also the managing the treatment impact on quality of life, and ensuring the long-term complications to be taken care actually. See, our aim is to there is much beyond glycemia. That's what. See, our aim is not only to control the A1C, the fasting post-lunch blood sugars, that is diabetes, and the hypertension and the cholesterol. There is much beyond this the glycemic control. So when it comes to the middle age, so maintaining a long-term control of risk factors and timely management of the clinical as well as the subclinical disease, and secondary prevention in patients with diseases or the events or the complications, and providing the integrated care. Very sorry to say this, that in our scenario, the Indian scenario, almost the type 2 diabetes mellitus patients, they are diagnosed along with a complication. Let it be a microvascular complication or a macrovascular complication. So when it comes to the older age, the protection from the events and complications, because that is the time where they develop all the complications of diabetes, complications of hypertension, the complications of dyslipidemia in the form of the microvascular events and the macrovascular events. So that is managing the multimorbidity and polypharmacy. This is the very important aspect as far as the older age people are concerned. There are multiple comorbidities. The patient has got diabetes mellitus, the patient has got hypertension, he's got dyslipidemia, he's got some one heart event, or might be in heart failure, might have landed up in the stroke. So along with this, nowadays the burning topic is the MASL and the MASH, the metabolically associated dysfunction related steatotic liver disease and all. So managing the tolerability and the quality of life. So they have some amount of cognitive impairment by the time they reach 70, 75, 80, and it goes on increasing, like cognitive impairment that might be a simple senile dementia. In some people it's pre-senile dementia, or in majority of the people this Alzheimer's is almost evident. So they might miss a pill, they might overtake the pill. So that is very important. And the considerations of the access and the cost of the care. These are the priorities according to the age. The patients may perceive the drug therapy as the complex burden. One out of the two patients suffering from type 2 diabetes in India are not adequately aware of the fact that they are at a renal risk, which impacts the treatment compliance, because whenever there is a renal impairment according to the EGFR, we need to titrate the dosage of the molecule, or we need to withdraw some molecules. What is to be used, what is not to be used is very important. So And 3 out of 5 patients diagnosed with type 2 diabetes in India do not follow up regularly for the medical consultation. This is the biggest practical barrier what we face in our day-to-day OPD. Once we give a prescription based on that particular the baseline tests on that particular day, the patients will come to us after sometimes 3 to 4 years or 5 years or even after a decade. So multimorbidity has got a significant impact on patients' perceived burden of treatment, necessitating less disruptive treatment options. And 1 out of 3 patients with type 2DM and CKD may be prescribed incorrect DPP4 inhibitor dose, which is associated with potentially increased risk of adverse effect. The treatment simplicity is associated with better adherence and outcomes. By now, you must be knowing that I am going to talk about a gliptin, the real renal gliptin, which is linagliptin. This is the research molecule of Boehringer Ingelheim, which is little bit very different from the existing DPP4 inhibitors, because this is the only one gliptin which has got 2 cardiovascular outcome trials, that is the Carbolina and the Carolina. And second thing is, this molecule once started, you don't need to monitor the kidney parameters at all. So at any point of the estimated glomerular filtration rate, you can happily continue this with 5 milligram of linagliptin, whereas other gliptins like sitagliptin, like the saxagliptin, like the other the vildagliptin, they need to be down titrated once the EGFR is around or less than 45 ml per minute. So this is the real burden the patients are facing. So they forget about this is my humble request and appeal to all the participants who are practicing diabetes. Do not please get into the trap of teneligliptin. Years together I have been telling you, teneligliptin is not a very safe drug and it is not approved by USFD. In that sense, even vildagliptin is also not approved by USFD, but it has got a robust data. Okay, this is the Indian gliptin, teneligliptin, which is approved in only Korea and Japan and India. So this never gets approved by the USFDA. And the dose, if you start the teneligliptin, I have seen many prescriptions like they give it BD to the patient, that is 20 mg 2 times a day. That increases the QTC the prolongation, and they land up in sudden arrhythmias and sudden cardiac arrest and death also. So the doctor doesn't know why the patient has died, and even the relatives also, they don't know why the patient has died. So it happens over minutes, that's all. So let's go to the next. This is the key treatment goals from the patient-centric type 2 diabetes care. This is according to the American Association of the Clinical Endocrinologists algorithm. The latest one is 2023. So the lifestyle modification underlies all therapy. They maintain or achieve the optimal weight and a choice of anti-hyperglycemic therapy reflecting the glycemic targets, and atherosclerotic cardiovascular disease and the congestive heart failure and the chronic kidney disease and the overweight bar obesity and the NAFLD. At that time it was called the non-alcoholic fatty liver disease. Now it is being changed to MASLD. That's what I said. Metabolically defective associated steatotic liver disease. And the choice of therapy includes ease of use and access. The optimal hold on for a second, please. Yeah. The optimal HbA1c is around or less than 6.5. This is according to the ACE and AA's, that is the recommendations of the ADA little bit vary from this when compared to this the American College of Cardiology and the American College of the Clinical Endocrinologists and the American College of Endocrinology and the American Heart Association. See, they say it's always better to be like maintain the A1C less than 6.5. So individualize all glycemic targets like A1C and the fasting plasma glucose and the post-lunch plasma glucose, and around the time, that is all the time, whenever you check around the 24 hours should be to the target. And like fasting, it should be at any time you see, let it be fasting or pre-lunch or pre-dinner, it should be somewhere around if the patient is on treatment, it should be like in between 80 milligram per deciliter to 130 milligram per deciliter. And the postprandial glucose that must be less than, or what we call the random blood sugar, that is the casual plasma glucose, must be around less than 180 milligram per deciliter. And the time in range is very, very important. So we need to see to that the patient is not above the range in time or below the range in time. So we should see to that 60 to 80% of the times the patient is always within the time in range. So then get to the goal as soon as possible. At least once you start the medication in a newly diagnosed type 2 diabetes mellitus or the drug naive patient, at least within a reasonable period of 3 months, you must be able to get this all the parameters, what I said, the glycemic triad, that is the fasting plasma glucose and the postprandial plasma glucose and the HbA1c. This is called glycemic triad, to the target at least within the 3 months. So, and at the same time, you must try to avoid hypoglycemia. So you must select the drugs which have got the very less incidence of hypoglycemia, certainly not the level 3 hypoglycemia or level 2 hypoglycemia. As far as hypoglycemia is concerned, you should see to that the hypoglycemia has got deleterious effects, like once the patient is in hypoglycemia, the level 1 progresses on to level 2. If not recognized, it moves on to the level 3 hypoglycemia. So where the patient is totally unconscious, he may get into coma if not treated, if not taken care properly, or he may have dysarthria, the central nervous system side effects, like he may have the stroke, the hemiplegia, hemiparesis, or the loss of speech, or sometimes heart attack, and last is coma, and final complication of hypoglycemia, if not taken care, is death. So don't take hypoglycemia so easily. Okay? So we have to take care of the hyperglycemia, which is a threat in the long term, but hypoglycemia is a threat immediately, which has to be attended and taken care very properly. So try to select the drugs which have got very less incidence of hypoglycemia. So that is like the DPP4 inhibitors, they have very less incidence of hypoglycemia. Likewise, you can have the SGLT2 inhibitors. So that whenever you want to initiate insulins, you should reduce the dose of the secretagogues, sulfonylurea secretagogues, and the dosage must be they started with the lowest dose as far as the insulin is concerned. And you want to, there is now a separate entity which everybody is focusing on all over the world, is the management of obesity, that is either the diabetes or the obesity or the diabesity. The GLP-1 receptor agonist like semaglutide and the once a week subcutaneous injections, and the tirzepatide. Semaglutide is a GLP-1 receptor like the receptor agonist, whereas this tirzepatide is the GIP and GLP-1 receptor agonist. It has got dual mechanism of action. That is the reason why we find the much weight reduction and the better the glycemic triad with the terzepatide. The brand name is Manjaro. You must be knowing all these things. And they have got jump bound also. This terzepatide for diabetes is called Manjaro, whereas in case you want to use it for patients without diabetes and only you want to target that, it is called Jabbound, but it is not available in India. They have not launched Lilly people. They are managing everything with only one molecule, that is Manjaro, whereas the Novo Nordisk people, they have got semaglutide in two different the segments, that is one for the diabetes segment, that is Ozempic, and one for the simple weight loss obesity, that is the Wegovy. And continuous glucose monitoring is highly recommended to assist the patients in reaching regular goals safely. And nowadays, continuous glucose monitoring is picking up a lot, and apart from the Abbott is the gold standard with the Freestyle Liver Pro. So many models have come that works for a period of 14 days. And the Indian companies also like B2, they are doing fairly well with a reasonable price. The difference is only the one thing, that is it is for 14 days, the Abbott, and this B2O and the other Indian companies, they give up to 1 day extra, that is 15 days. And the comorbidities must be managed for comprehensive care. So you see this cartoon, the current place of DPP-4 inhibitors in the evolving landscape of type 2 diabetes management. You see the time to beat RDO. So the patient profiles that are more likely to benefit with DPP-4 inhibitor use, we divide it into like the frail patients on the left hand side and the older patients on the right hand side. On the patients with low values of insulin resistance markers and patients with who are at high risk of cardiovascular disease and the renal risk already on SGLT2 therapy, and the patients with excess weight and the patients with recent type 2 diabetes at low cardiovascular risk, and patients who are vulnerable for this particular hypoglycemia. And you can see a DPP-4 inhibitor should optimally inhibit at least more than 80% of the DPP-4 enzyme activity throughout the 24 hours. So that is measured at RAW. So you can see the different molecules, that's what I said, the sitagliptin, vildagliptin, saxagliptin, teneligliptin, and the real renal gliptin is linagliptin. I told you why it is called the real renal gliptin, because it doesn't require any sort of dose titrations. You don't need to decrease the dose. You don't need to decrease the dose of the linagliptin once you start it, whatever be the EGFR. And even when the patient is on dialysis, you can use this along with insulin. And even post dialysis also, the kidney transplantation, you can use this along with the insulin. And even after that, there is a separate entity called the new onset diabetes after any transplantation. Let it not be specifically the kidney transplantation, any transplantation like liver transplant or lung transplant or heart transplant or any other the pancreatic transplant, because this develops because of the drugs what we use to mimic the body to send a signal that it should not, the body should not reject this particular organ. That is what we call this the cyclosporin and azathioprine. These are all the drugs which we use to mimic the physiology of the body. So the side effect of that definitely will be the new onset of diabetes. It is not type 1, type 2, nothing. It is a simple diabetes after transplant. And you can see the percentage of DPP-4 inhibition at 24 hours at clinical doses. That is The sitagliptin we use in 100 mg once a day. That is that inhibits more than 80%. And vildagliptin 50 mg BD. And nowadays even the OD preparations have come 100 milligram OD sustained release, and that is also to the target 80%. It is going to inhibit according to what we said. The way we measure it with that's it. So the saxagliptin is 73.5, and I request all the participants please avoid this particular saxagliptin as far as the heart failure is concerned, because this particular molecule from AstraZeneca has got a tendency to induce heart failure. So rule out saxagliptin. And the linagliptin, that is more than 80% at the dose of 5 milligram OD, and the teneligliptin, that is 61.8%, 20 milligram once a day. So when we look at the half dose, that is 50 milligram of this sitagliptin once a day has got only 67.9% of the DPP4 inhibition, and likewise vildagliptin at 50 milligram half dose, that is OD, has got 28.5. It's very very poor respectively. And when you take the saxagliptin, the 2.5 milligram OD has got 50% of DPP4 inhibition, and whereas this particular 2.5 milligram of linagliptin has got highest, that is 76.8% of DPP4 inhibition in a period of 24 hours, and 10 milligram of the teneligliptin 53.1%, because I don't have experience with the teneligliptin, and that is only the one which I have not tried. I have never generated even a single prescription of teneligliptin for the fear of the QTC prolongation and the afterwards the complications. So I have used sitagliptin, I have used vildagliptin, I have used saxagliptin. I used to use and I stopped after the SAVAR TIMI58 study has come, that is the cardiovascular outcome trial for this. And TECOS is the cardiovascular outcome from sitagliptin, and vildagliptin doesn't have any cardiovascular outcome trials. But there is one trial showing the side effects of the vildagliptin, that is VIVID trial, VIVIDD. That shows that the vildagliptin increases the left ventricular volumes. So in future the patient may be at risk of developing heart failure. So try to avoid in such cases when you think of this particular patient may land up in either acute heart failure or chronic heart failure. Please avoid saxagliptin. The teneligliptin, I don't have experience. I never recommend or endorse a particular molecule. See, I recommend only linagliptin as the current scenario goes, and you can use even sitagliptin also. It's doing good. The only thing is you need to be very vigilant with regards to the renal parameters. Whenever you do serum creatinine, you calculate the estimated glucose, this glomerular filtration rate. You need to down titrate from 100 to 50, and after a period again, if it is the EGFR is less than 45 ml per minute, you need to come down from 100 to 50, and it goes below 30 ml per minute, you need to go for 25, and at some point you need to stop, totally withdraw the drug. So what I say is you have to select a molecule. All are off patented, and nowadays you better know this also. All are available at the same cost. Price is not at all a barrier. So you can select the best molecule instead of selecting a wrong molecule. That's why I said the linagliptin is the real renal gliptin. So the glycemic parameters influenced by DPP4 inhibitors. So it's about linagliptin, the pooled data from the 6 randomized control trials and from 2,700 patients, and the duration was 24 weeks. So you can see the baseline reductions. So the HbA1c was reduced by 0.63%, and the fasting plasma glucose correspondingly like 16.9 milligram per deciliter, and the postprandial glucose by 52.2 milligram per deciliter respectively. And when we measure this particular the HOMA B, the HOMA IR and the HOMA 2 IR has come off late. So when we measure the insulin resistance, it shows that very clearly the insulin resistance has gone down, thereby the improves the insulin sensitivity by 16.5 milliunits per liter. So whatever you take, all the parameters including the glycemic triad and the particularly this insulin resistance also is decreased, and thereby the insulin sensitivity is increased by this linagliptin just within a period of 24 weeks. And the DPP4 inhibitors, they reduce HbA1c without increasing the risk of hypoglycemia. Treatment effect of various DPP4 inhibitors in monotherapy per the US or the European Union labels, placebo corrected adjusted mean change from the baseline HbA1c after 18 to 24 weeks of the treatment. You can very clearly see this the linagliptin on the left hand side and the saxagliptin in the middle, sitagliptin in the middle. On the right hand side you can see the reductions this particular regarding the HbA1c. So the robust evidence demonstrates the comparable glycemic efficacy with the different DPP4 inhibitors. You can see this the A1C reductions with the all DPP4 inhibitors, like starting with the allogliptin and the linagliptin and the saxagliptin and the sitagliptin and the vildagliptin. I always tell you the sitagliptin has got the maximal the reductions in the A1C. That is not much when compared to linagliptin. It is 0.74 when compared to the sitagliptin, which is 0.75. See, the allogliptin reduces the A1C by 0.74%. The same is with lina. The saxa is 0.61%, and the sita is 0.75%, and the vildagliptin is 0.67%. So this the graphic representation, this is the use of linagliptin associated with a better 24-hour glycemic control, and you can clearly see the straight black line is the high metformin, that is, and the dotted line you find is the low metformin dose with the dotted line plus a DPP4 inhibitor. So you can clearly see that the DPP4 what we have selected in this trial is linagliptin along with low dose of metformin, and you can clearly see the low dose of metformin has got a better glycemic curves actually. You can clearly see that the end of the day, this is the winner when compared to the high dose of metformin. See, that is the trial called the verified trial that was done with the metformin combining with the vildagliptin. That is the verified trial, and I was one of the principal investigators of that. The results of this particular verified trial rolled out in the 2019 EASD Barcelona, where it has shown that the original metformin you start alone may be effective for a period of 3 years, and later on it slowly takes a uptrend curve. So the result of this particular trial with vildagliptin and lina, this metformin, as shown in verified trial as that a sustainable 6-year efficacy of the metformin with a better the glycemic control is seen with the verified trial. That is the simple essence of this particular verified trial. So the 24 hours continuous glucose monitoring data in patients receiving high dose metformin and the low dose metformin with linagliptin, DPP4 inhibitor. The curves are expressed as mean plus or minus standard deviation. So this is a graphic representation showing that linagliptin is associated with 82% of lower risk of moderate to severe hypoglycemic events versus glimepiride. This is called the Carolina study. So the beginning I said the only the gliptin in the world which has got the two cardiovascular outcome trials. One is the Carolina and the second is the Carolina. It is for the first time I think in the world they have taken an active comparator. The active comparator was the glimepiride. The what we call the modern sulfonylurea, the glimepiride was taken into the trial of Carolina, and the results of Carolina were very distinct. That the glimepiride had a more increased number of hypoglycemia, and the second point is the weight gain with this glimepiride was like 5 kilos over a period of 5 years, and it stayed just like that after even the study period was 6.5 years. So this linagliptin was compared with the glimepiride, and the inference is barring these two side effects of, we know all the sulfonylureas have the tendency to have the more incidence of hypoglycemia. That is the reason why we have stopped using this glibenclamide or glyburide, and even the patient is on glibenclamide, we call it glibenclamide, and the other world that calls it glyburide. Once the patient attains 60 years of age, it is high time you have to withdraw this particular glibenclamide, keeping it in the view that the forthcoming serious hypoglycemic events where it has led to several deaths if not treated properly, if not taken care for the basic difference between the glibenclamide and the other sulfonylureas is it sticks to the cell membrane surface of the beta cell, and it keeps on squeezing even you withdraw. So generally for insulin, which is a short acting drug, or other the sulfonylureas, we admit for a period of 24 to 48 hours, but it is mandatory that the patient is on glibenclamide or glyburide and the patient gets into hypoglycemia. It's a dictum that it's mandatory that the patient should be kept in observation for 72 hours. That is the stabilization time. Then only you have to discharge him with holding holding this particular molecule and replace it with a molecule which doesn't have the hypoglycemic risk. So this the black is linagliptin and the green is the glimepiride. So you can see this the curve started getting separated even from the beginning itself until the end. See the rate is 8.4 per 100 patient years. The number was 927 patients. That was with glimepiride, whereas the rate was 1.4% per 100 patient years. You can see this the gross variation in this the rate per 100 patient years is 1.4 for linagliptin, whereas it is 8.4 for this particular glimepiride, and the patients were 195 patients. So the duration was around 6.5 years. It's a very long study, and the difference between the Carolina and the Carolina is they have taken the very high risk cases like the cardiovascular and the renal parameters were high in Carolina, whereas this Carolina, it's an active comparator was taken, this particular glimepiride, and the less severe cardiovascular events and less severe the chronic kidney disease patients were selected. That is the difference between the Carolina and the Carolina. And linagliptin provides a greater A1C goal achievement without hypoglycemia, weight gain, and rescue medications versus glimepiride. That is the take home message from the Carolina. That's what I have told you. You can clearly see the green is the glimepiride and the black is the linagliptin also. The all patients you can see the A1C goal achievement. And the next is less than 65 years. You can see a clear spurt in between linagliptin and the glimepiride. And 65 to 75 years also, it's very quite evident. And even the patients over the 75 of the years, that also has got a clear spurt between the glimepiride and the linagliptin. That's what I said, that try to select a molecule for the patients above 70 or 75, 80. They are like linagliptin, which doesn't produce the hypoglycemic events. And the take-home message of Carolina in one single sentence is the linagliptin was shown to be non-inferior to glimepiride with regards to cardiovascular safety. That's it. So the key secondary sustainability endpoint, the proportion of the patients achieving the HbA1c goals of around or less than 7% and without the rescue medicines, without the moderate and severe glycemia. I said it may cause sometimes, if the other drugs are used, it may lead to the level 1 hypoglycemia, which is mild hypoglycemia otherwise, but it never gets into the moderate and the severe or the level 2 or level 3 hypoglycemia, and without more than 2% of weight gain. That's what I said. The linagliptin the almost is weight neutral, though it doesn't decrease the weight, but it never increases weight like sulfonylurea. So the different DPP4 inhibitors have distinct clinically relevant drug profiles. Like you see linagliptin, saxagliptin, sitagliptin, teneligliptin and the vildagliptin. And on the left hand side you can see the DPP4 enzyme binding affinity. These are the parameters: terminal half-life, DPP4 inhibition at 24 hours post-dose, and renal elimination, and the dosage adjustment in renal impairment, and the dosage adjustment in hepatic impairment. So you can go through the parameters like, okay, the whatever be the parameter, like you have the DP4 enzyme binding affinity is highest like more than 100 hours. That is the longest acting the DPP4 inhibitor, and the terminal half-life is more than 100 hours, and the inhibition at the 24 hours post-dose we have seen in the earlier slide is more than 80%. Renal elimination, this is why we call it a real renal gliptin. The only reason being the linagliptin, the remnants are eliminated through kidney by only 5%. The main organ that eliminates linagliptin is liver here. So that is the reason we don't need to down titrate the dose or up titrate the dose in any point of EGFR. So dosage requirement is not adjusted, and the dosage adjustment in renal impairment not required, and even in the hepatic impairment also not required. So when compared to the other parameters, so let me cut it short. So linagliptin scores over sitagliptin and the saxagliptin and the teneligliptin and the vildagliptin in all the parameters what we have discussed just now. The unique pharmacokinetics of linagliptin, the high potency and the slow dissociation. See, when we start the linagliptin, generally we start with 5 milligram once a day linagliptin, and it is like a small free or unbound fraction which rapidly is eliminated, short accumulation of plasma half-life 12 hours, and on the left hand side you can see the 95% of this particular linagliptin is bound to the plasma proteins, mainly to the DPP4 receptors, and leads to slow dissociation and a long terminal half-life of this linagliptin to be more than 100 hours. The inference is the high potency, the 5 milligram ensures more than 80% of the DPP4 inhibition over a period of 24 hours, and very fraction bound to the DPP4, very slow dissociation, and very small free unbound fraction which is eliminated very rapidly. This is seen on the right hand side, and the slow dissociation is seen on the left hand side. And linagliptin has the lowest free drug concentration within the DPP4 class. You can clearly see this. This is 0.35 with linagliptin, whereas 10 with saxagliptin, and 219 with sitagliptin, and more than 267 with vildagliptin. Higher free drug concentration may increase the load for hepatorenal elimination and may be potentially associated with higher risk of off-target adverse events. So the approved clinical use of DPP4 inhibitors in patients with hepatic impairment. See, you can definitely see that the mild to moderate impairment of the liver and the severe impairment, both the groups you can happily use linagliptin. Not only with the renal gliptin, we have to call it even the hepatic gliptin also. So sitagliptin is for mild to moderate impairment, but it is not studied with severe impairment. That is the chronic liver disease, either with this the cirrhosis or the next stage is hepatocellular carcinoma. And the vildagliptin is not at all recommended in any scenario of this particular hepatic impairment. And saxagliptin can be used in both these scenarios, but it has got the tendency like you need to down titrate as far as the renal impairment is concerned, and it has got a tendency to produce the heart failure. So we need to avoid, and no wise physician treating diabetes selects saxagliptin or this particular 10-L-gliptin. And the 10-L-gliptin, so like sitagliptin, it can be used, but I don't have any experience. So the vildagliptin and the 10-L-gliptin observed increase in enzyme levels with mandatory LFT assessment before initiation of and at frequent intervals while the treatment is going on, and discontinue the drug if abnormalities are observed. So nowadays let me finish up. Saxagliptin dose adjustment with the strong CYP inducers. So nowadays the international the liver bodies have made it a mandatory dictum that every patient, every individual, not patient, I'm sorry, every individual must be screened for this liver function test to rule out the transaminitis, that is the elevation of the AST, ALT or the alkaline phosphatase, and also one ultrasound scan abdomen, abdomen to rule out any involvement of the fatty liver, maybe grade 1, grade 2 or grade 3. So in my clinic I routinely do for that is for normal population, whereas in our clinics we see the exclusive the diabetes, hypertension, dyslipidemia and the obesity, PCOS and all, thyroidism, hypothyroidism, hyperthyroidism, more of the diabetes and less of this particular the other domains what we said, the endocrine domains. So the best molecule to select either in the renal impairment or in the liver impairment, hepatic impairment, or even without that also, once you start a linagliptin, you don't need to worry about all these things. So every time LFT is a cumbersome procedure, but sometimes at least once in a year it's mandatory that the patient suffering from type 2 diabetes and other comorbidities must get done this LFT and the ultrasound scan to rule out this fatty liver. Once you find a fatty liver, then the next step, the LFT is abnormal with the transaminitis, the enzyme elevation without any jaundice, that is normal serum bilirubin with the enzyme elevation, it is called transaminitis, and fatty liver change, then we should just get this fibroscan done to categorize the FIB1, FIB2, FIB3, FIB4, FIB5, and the treatment varies from 1 to 1. That is so. I sincerely appeal to all the participants that apart from the screening for this diabetes, hypertension, dyslipidemia, heart disease, and the strokes and all what we know, the kidney impairment, and you need to focus more on the liver now. The liver diseases can cause type 2 diabetes, and type 2 diabetes can cause liver disease that may lead to from a simple fatty liver to that is what is called the mast to mash to the fibrotic stage, that is called cirrhosis, and the next stage is hepatocellular carcinoma. And the consistent efficacy in patients with type 2 diabetes and hepatobiliary disorders, you can very clearly see this the good effects of the linagliptin, which is given in the black when compared to the placebo, which is quite evident. And this is the slide showing linagliptin but not the sitagliptin inhibited the transforming growth factor beta 2 induced endothelial DPP4 activity and the endothelial mesenchymal transition. So you can clearly see that the renal DPP4 activity induces the transforming growth factor, that is TGF beta 2, which stimulates the endothelial mesenchymal transition and in the pathogenesis of CKD. Linagliptin but not the sitagliptin demonstrates in vitro reduction of the pathogenesis and associated profibrotic signaling. So whatever the parameter you take, linagliptin scores over the other gliptins. Not that I am endorsing the linagliptin. It is backed up by the evidence-based medicine and backed up by the robust cardiovascular outcome trials, the Carbolina and the Carolina. And the linagliptin is the DPP4 inhibitor with lowest kidney excretion rate. I have told you it is only 5% is excreted through kidney, the remaining 95 through liver. Whereas the renal elimination of sitagliptin is 87% and vildagliptin 85%, alogliptin 76% and saxagliptin 75% respectively. The dose adjustment is required in patients with kidney impairment and or drug-related kidney monitoring. And for the 5% linagliptin, no requirement of any additional dose-related kidney functioning monitoring. And the consistent glycemic efficacy with linagliptin across the stages of kidney function, adjusted mean HbA1c change from baseline versus placebo by degree of the kidney parameters, and from normal to mild kidney impairment to moderate kidney impairment to severe kidney impairment, and all the stages we used only linagliptin 5 mg once a day. And the pooled analysis of the the phase 3 trials at 24 hours and the randomized control trial at 52 weeks shows the superior efficacy of the linagliptin. You can clearly see the diagram. And in inappropriate renal dose adjustment for DPP4 inhibitor agents and risk of adverse events in patients with T2DM with CKD, that is 82,000 patients with type 2 diabetes and the CKD, that is the Korean National Database, and inappropriate dosing, that is 1 out of 3 patients in DPP4 inhibitors are seen in the overall study, that is inappropriate dosing of DPP4 inhibitors. See, the 2 out of 5 patients are on sitagliptin, 1 out of 4 patients is on vildagliptin. And what happens if the vildagliptin is continued, if it is not down titrated, not properly monitored, the patient doesn't come to you at all. and he'll ends up in a soup, whether he develops the muscle and the mash and the fibrotic stage, that is cirrhosis. So the patient is gone with the wind once you take up a wrong molecule. And I don't say this sitagliptin is a wrong molecule, but you have to be very cautious with regards to all the parameters. So you need to continuously monitor the renal parameters and the hepatic parameters like liver function test. And no patient on linagliptin. This is the pathetic part of it. See, out of 82,332 patients in the Korean database, nobody is on linagliptin. This is the wrong selection and the inappropriate selection of the molecule and inappropriate dosing also. And clinical outcomes on the right hand side with the inappropriate dosing of DP4 inhibitors that leads to the severe hypoglycemia, that is the risk of more than 19.2%, which is statistically significant, where the p-value is less than 0.05. And emergency department visits, that is the incidence of emergency department visits is more than around 7.4%, which is also statistically significant, where the p-value is again 0.05, and the all-cause death is increased by 11.5% risk, and also it is statistically significant, the p-value is 0.5. And dosage adjustment for the therapies in EGFR less than 45 ml per minute per 1.73 meters square of the body surface area. The ADA KDIGO consensus statement. The KDIGO is the international guidelines. The latest 2026 guidelines have rolled out from this KDIGO. The diabetes management in CKD, you can clearly see the linagliptin. All the others, they require they like allogliptin and the sitagliptin. The stage 3B, you need to down titrate, like okay, the maximum dose you can use is only 12.5 versus 25 milligram, and the sitagliptin maximum is 50 milligram. So you need to down titrate from 100 to 50 again, and the maximum of 6.25 daily, and the stage 4 and stage 5, that is so the linagliptin no dose requirement is required, whereas all others they need to either require they down titrate the dosage, or sometimes we need to withdraw. You can see the sulfonylureas also, the glimepiride, the glipizide and the glyburide. So